very good evening to everyone. Today's topic for academic session is management of paragangliomas of head and neck, focusing on differential diagnosis, imaging findings, management algorithm with evidence from our literature. Starting with introduction, it's an uncommon neuroendocrine tumor derived from extraadrenal ganglion of autonomic nervous system. Embryologically, its origin from neural crest cells and makes 10 from skull base to pelvis. There is almost 20 different locations have been reported for head and neck paragangliomas alone, with the carotid body, vagal body, jugular tympanic region making up the most common location. And another regions reported are larynx, orbit, trachea, thyroid, and a nasal cavity. Sporadic and a familial variants exist in the population. Approximately 24% of all paragangliomas may be familial, with this number increasing to 35% for head and neck paragangliomas. There are multiple susceptibility genes for paragangliomas have been identified, with the mutation of succinate dehydrogenase being the most common. So approximately 90% of tumors occur in the adrenal paraganglion, which is called as pheochromocytomas. Head and neck paragangliomas comprise a range from 65 to 70% of paragangliomas, and it accounts 0.6% of head and neck tumors, with overall incidence of 1 in 30,000 to 1 lakh of head and neck tumors. So there is a study on locations of all paragangliomas in a study population from 1978 to 1998 by Wasserman, in which they have said that head and neck paragangliomas has the highest numbers, that is around 69%, among which carotid body are the most common. This is a pie chart showing this is another distribution for paragangliomas in a pie chart form, which is showing that the carotid body tumors has a majority of the cases, followed by a glomus jugular, then glomus intervagale, and then followed by a mediastinum and other upper aerodigestive tracts paragangliomas. So the rate of growth of the tumor, it has a range from 0.8 to 2 millimeter per year. Basically, paragangliomas are classified on the basis of sympathetic and parasympathetic chains. And among that, parasympathetic chains has a highest number of head and neck extraadrenal paragangliomas, followed by a thorax and other non-chromaffin cells regions. And in sympathetic cases, abdomen has the more cases, followed by a thorax, and then it comes as a head and neck paragangliomas. So the maximum number of cases are from the parasympathetic region. Secretory versus non-secretory. There is a production of metanephrines and a catecholamines, which is a characteristic for pheochromocytomas, as well as sympathetic paragangliomas. And they are most commonly found along the thoracic, abdomen, and pelvic paravertebral axis, while head and neck paragangliomas rarely secrete catecholamines. So mostly they are non-secretory, range from 70 to 95%. And less than 4% were secretory, which needs a pre-operative care in the form of alpha blockade. And the secretory paragangliomas are more likely to be a familial. Coming to the genetics of the paragangliomas, so up to 40% of head and neck paragangliomas have identifiable germline mutations. Over 70% of multifocal paragangliomas are associated with germline mutations, and the most common mutation seen in the succinate dehydrogenase D and B genes, which are autosomal dominant. However, a significant proportion of patients carrying a germline mutation will not have known family history. This is reported, there's a series reported by Rana et al., in which they have said that only 4 patients among 16 patients with a germline mutation had a positive family history at initial assessment. There's an inheritance pattern for paragangliomas. So the most common gene associated with paragangliomas is SDHD, that accounts for 80 to 90% of cases. Then it is followed by SDHB, and then it's SDHC. While the malignancies are present only in cases of SDHB genes. Multifocality are present and more commonly in SDHD gene. Then it's followed by SDHB genes, and then less than 10% were present in SDHC gene. These all are monogenic autosomal dominant genes, and the penetration rate were higher in SDB and HG, and as for SDHD it was not reported. So there's an algorithm for genetic testing for patients with head and neck paragangliomas. So there's a multiple predictors which has to be there to do a genetic testing. So these predictors includes if there's in a positive family history preceding pheochromocytomas, if there's a multiple tumors, malignant tumors, a patient young age like less than 40 years old, and a male gender. If any of these predictors are not present, then there is no need of further testing for genetic. But if any one or more predictor present, then we have to look for, is it a solitary head and neck paragangliomas or it is a multiple head and neck paragangliomas. Then next we have to see if does they have a negative family history or a positive family history. With the solitary head and neck paragangliomas, if the patient is having a negative family history, start with doing the SDHB testing. If it's come negative, then go to the SDHD gene, and then if it's come negative, then go for the SDHC genes. And for positive family history, start with the SDHD genes. If it comes negative, then go for the SDHB and followed by a SDHC gene. However, the Endocrine Society and European Society of Endocrinology said to consider and discuss genetic testing in all paragangliomas with head and neck. The most common screen were SDHD, B, C, A, F, factor 2, and VHL syndrome. The reason behind could be SDHDB has a higher association with a malignancy. Hence, one should err towards surgical management in them, and the familial have a higher propensity to be secretory. Hence, that would mandate a worker for secretory paragangliomas before any other definitive treatment. Coming to the diagnosis of head and neck paragangliomas, starting with the imaging, it could be a CT, MRI, angiography, and other functional imaging techniques. Starting with a cross-sectional imaging, both CT and MRI have a similar sensitivity that range from 80 to 90% and specificity of 90%. MRI over CT for initial diagnosis and surveillance were considered more common. And there's a reason. There has to be a typical features which is present for cross-sectional in a cross-sectional imaging, that is a salt and pepper appearance, which is because of hemorrhage and flow voids present in this vascular tumor. As we know that the paragangliomas are very vascular in nature, so it leads to internal voids which seen as a hypointense in T2 images, and there's an internal hemorrhage seen as a hyperintense in T1 or T2 images, which gives a characteristic salt and pepper appearance for the paragangliomas. In angiography, there's a blush tumor appearance which gives a multiple enhancing feeding peritumor vessels, and which helps in identification of feeding vessels and can guide for subsequent embolization or a surgical approach. We have to go for the treatment. There's another more common tumors in the head and neck regions are like schwannomas and neurofibromas, and these are differentiated from head and neck paragangliomas in the term that neuroschwannomas in any other tumor is well defined with the missing of salt and pepper appearance, which is present in head and neck paragangliomas. There's a functional imaging in paragangliomas. The physiology behind functional imaging for paraganglioma is that it has a neuroendocrine differentiation. There's a hormone called somatostatin, which is a inhibitory growth hormone, which binds to the somatostatin receptors, which are overexpressed in external adrenal, extra-adrenal paragangliomas that allow for excellent detection of these tumors. The three main gadolinium SSTR ligands used for PET CTs are DOTATE, DOTATOC, and DOTANOC, which have a high lesion-based sensitivity for head and neck paragangliomas. They can detect up to 96% of lesion, including sub-centimeter tumors, which may influence treatment decisions. And another functional imaging is MIBG scintigraphy. This is high sensitivity for overall paragangliomas, but it has a low sensitivity for head and neck paragangliomas. Now I'm coming to discuss some common head and neck paragangliomas, which the one is the most common is carotid body tumors. It arises from the paraganglia at the carotid body, which is chemoreceptors. Clinically, it shows a signs. Clinically, it looks like a painless, gradually enlarging mass in the upper neck below the angle of the jaw. It's rubbery, non-tender mass in the lateral neck. There is a positive Fontaine signs present, which means it can move freely in a horizontal plane than a vertical plane. There is a presence of carotid brood, or the mass may be pulsatile. The metastasis risk of carotid body tumor is 6%. Most cases are unilateral and sporadic in nature, but bilateral multifocality may also occur. It's usually in hereditary cases. Radiologically, as we can appreciate in these two axial and sagittal image, there's a Lyell sign present, that is the splaying of the external carotid and internal carotid artery. And this is a typical sign present for carotid body tumors. As the tumor increases, patient may develop dysphagia, deficits of cranial nerve like 9, 10, 11, and 12, and hoarseness of voice, all of which get affected in neck region. And due to its the reason behind its close proximity to the adjoining nerves and vessels. This is the classification proposed by Shamlin's, which is called as a Shamlin's criteria. So they classify into three class 1, 2, and 3. One is the tumor is localized to a carotid bifurcation with little attachment to a vessels. Second is tumor partially surrounds a carotid artery. Third is tumor intimately surrounds carotid artery that is more than 270 degree or equal to 270 degree. So there's another modification of this criteria proposed in 2006 by notice. That is class 3B, which includes any of the class 1 to 3, where
hello, sorry Afshan, but iPhone 13 this iPhone person. You are the host. iPhone 13.
So there is a modification by Luna Ortiz, which is given in 2006 for Shamlin's criteria. So there is a class, they're given another class 3B, which includes tumors of any class 1, 2, or 3, where there is an infiltration of the vessel wall and not just a circumferential encasement. There's a research paper by Arya et al. Published in 2007 by TMH Group. They have given an objective criteria to predict the Ambulance group on MRI images. So what they have did a radiologic classification into three types, 1, 2, and 3, based on the maximum degree of circumferential contact of a tumor with internal carotid artery. So as with in this image, we can see that they draw two intersecting lines from the center of the internal carotid artery and the point of contact of the circumferential of the vessels with the edges of the tumor obtained in the angle for type 1 tumor, and for this angle which we obtain by the intersecting line is the angle for type 1 tumor, while for type 2 and type 3 tumor, the actual angle is the measured angle minus from the 360-degree. So in this image, we can see that actual angle for type 1, the actual angle is 150-degree. So anything which is less than or equal to 180 is come under type 1. For type 2, they have just in this image, you can appreciate that this angle which is forming is 150. So for type 2, if we minus this 150 from 360, it comes 210 degrees, so it comes under type 2. So anything above 180-degree and less than 270-degree is comes under type 2, and if the same thing, if anything comes above the 270-degree, that comes under the type 3. This gives a objective criteria to Chambline's group. There's next, the second most common head and neck paraganglioma is jugular paragangliomas. It arises from the paraganglia associated with the adventitia of the jugular bulb. Clinically, may have a unilateral tinnitus and a hearing loss, tends to grow aggressively beyond the limits of the jugular foramen, causing bone erosion and reaching adjacent foramen as well as eustachian tube. Radiologically, it gives a moth-eaten appearance of the jugular fossa. So the CT of the temporal region has the mandatory for the jugular paragangliomas. As in this CT, we can appreciate in this axial view, we can appreciate there's a mouth-eaten appearance of the jugular fossa area, and this is the classic radiological feature for the jugular paragangliomas. Next, coming to the tympanic paragangliomas, it has a marked female predilection with a later age of onset, that is around 60 years. Arises from the tympanic branch of the glossopharyngeal nerve. Bone involvement is rare and the ossicles are typically spared. Like jugular paragangliomas, tympanic paragangliomas frequently present with a pulsatile tinnitus and or a unilateral hearing loss, but are typically smaller and less aggressive. So there would be a expansion of the bone rather than the mouth-eaten appearance. Then next is another variation of jugular paragangliomas is that a jugulotympanic paragangliomas. It's a slow-growing, usually present with pulsatile tinnitus with or without conductive hearing loss, facial nerve paralysis, vertigo, a hoarseness, a paralysis of the lower cranial nerve, and bluish pulsating mass behind the tympanic membrane can be seen. So when there is an invasion of middle ear, when there is an invasion of middle ear by a jugular paraganglioma, the term is used as a jugulotympanic. As we can appreciate in this axial view, that it is in a tumor from jugular area is penetrating the middle ear. Coming to the vagal paragangliomas, it is an uncommon head and neck paragangliomas, and it can occur bilaterally and a multifocal. Typically seen where the vagus nerve exists, that is the jugular foramen, inferior nodose ganglion. Dizziness, blood vision, facial droop, dysphagia, neck mass, pain, cranial nerve deficit, Horner syndromes are the few clinical features for vagal paragangliomas. Due to posterior and a lateral path of the vagus nerve, with respect to internal carotid and external carotid artery, both the arteries are displaced anteromedially. We can appreciate this in the axial views. So now coming to the classification for jugulotympanic, there's a classification given by Fish. So they are basically classified into A, B, C, D. So any tumor which is limited to ear cleft comes under A. If it tumor is limited to tympanomastite complex, it goes under to B. C is further classified into C1, C2, C3. So anything limited to the vertical portion of the carotid canal is C1. If the vertical portion is invaded, it is C2, and if the horizontal portion also included, then it comes to C3. And D were the extents of the intracranial extension. That is, if less than 2 centimeter, it's to D1, and if more than 2 centimeter, it's D2. There's another classification given by Glasscock-Jackson on a tympanic and a jugular paragangliomas. So for tympanic, the one is tumor limited to cochlear promontory. Two is tumor completely fills middle ear cleft. Third is tumor fills middle ear and extends to a mastoid. And four is it extend into external auditory canal, may extend anterior to the internal carotid artery. For jugular paragangliomas, one is small tumor involving jugular bulb, middle ear, and mastoid. Two is tumor extending under the internal acoustic canal, or internal auditory canal, and may have intracranial extension. Third is tumor extending into the petrous apex, may have intracranial extension. And the fourth is tumor extending beyond the petrous apex into the clivus or a intratemporal fossa. There's a classification for vagal paragangliomas also by Netterwils. A is confined to neck, B is in contact with jugular foramen, and C is extended into or beyond the jugular foramen with or without intracranial extension. So these are the cross-sectional image where we can differentiate carotid body tumor from the vagal tumor. So the classic feature that is playing is seen in the carotid body, while in vagal there is an anteromedial displacement of the vessels. Now coming to the tissue diagnosis, there is no role of FNAC in the paragangliomas because of highly vascular nature. So there is chances of bloody aspirate and cause hematoma due to high flow. So paragangliomas diagnosed essentially was by a radiology. Histopathology, there is a chief cell known as Zelban, though it is not a classic architecture which is universally observed. So immunostaining of the paraganglioma is more important. So it is positive for neuroendocrine markers including chromogranin, synaptophysin, NSE, CDFS, CD5, CD56, and S100. The least was S100, which is not specific. And it's negative for cytokeratin neuromarkers. It is useful in differentiating head and neck paragangliomas from other epithelial-derived tumors mimicking head and neck paragangliomas. Examples are neuroendocrine carcinomas, Merkel cell carcinomas, and medullary thyroid carcinomas. These are the few most common differential diagnoses according to the region of the paragangliomas. For carotid body region, the DDs include carotid artery aneurysm, vasculitis of the carotid artery, lymphadenopathy, schwannomas, brachial cleft cyst, accessory thyroid gland. For vagal, the DD includes schwannomas, neurofibromas, lymph node lymphomas, ganglioneuromas, hemangiopericytomas, and other miscellaneous lesions like abscess, internal carotid artery aneurysm, internal jugular vein thrombosis, vascular malpositions, organizing hematoma. For tympanic region, the middle DD includes middle ear adenoma, meningioma, and aberrant vascular structures like jugular vein, internal carotid arteries. Then for jugular, the DD includes schwannoma, meningioma, plasmacytoma, carcinomas, chondrosarcomas, and tumor extension from nasopharyngeal carcinomas. So all from according to all this, the diagnostics, the initial workup for the paragangliomas starts from see for any signs and symptoms, family history, incidental finding. Go for the initial workup first by imaging, and next is biochemical testing. In imaging, the loco-regional assessment is important by can be done by using CT, MRI of head and neck. And for whole body imaging, MRI skull based to pelvis, or a functional imaging like gallium 68.8 PET CT is acceptable. Biochemical testing includes plasma-free metanephrine concentration. If anything comes positive, that if anything gives a diagnosis for head and neck paragangliomas, refer to the skull-based multidisciplinary team. Then go for the genetic testing. Discuss succinate dehydrogenase gene mutations. Target genetic testing if syndromic patient were present. Consider familial testing. If the disease is isolated, then according to the area, that is carotid body treatment and non-carotid body treatment pathway should be considered. And if the disease is multifocal or a metastatic, for multifocal, multidisciplinary decision should be intervened, and which tumor should be target is should be discussed. For metastatic, systemic versus targeted therapy should be intervened by a MDT team. Now coming to the management of paragangliomas. So the most common issue while considering appropriate management for head and neck paragangliomas include that the tumor is very vascular in nature, slow growing, implication of its on cranial nerve injury or palsy via tumor compression or versus iatrogenic injury. Age group, generally it affects young individuals, so we have to see which patients need to get treated, or which should be kept in the observation. Comorbidities, tumor size, tumor location, symptoms specific to each type of head and neck paraganglioma. These are the factors which should be considered for the appropriate management for head and neck paragangliomas. This is study by Heatstman et al., in which they have said that carotid body tumors often demonstrate growth over long follow-up time periods, and the large tumors like Champlain 3 result in higher rates of cranial neuropathy, which range from 12 to 79%. And another retrospective review of observation approach in head and neck paragangliomas demonstrated new complications, mostly cranial neuropathies, in 10% of patients with carotid body tumors, 14% with vagal, 15% with the jugular tympanic. During our observation, median follow-up of 5.3 years, and many of them which occurred are the non-growing tumors. So the option we have for the management of paraganglioma includes surgery, observation, or radiotherapy in no particular orders. Starting with the management of carotid body tumors. So if the skull-based teams of think about the familial history, cranial nerve palsy, and a secretory nature of the carotid body. If any of them is answer is no, then we can go for the active surveillance, which includes regular clinical examinations and a radiological follow-up initially first 6 monthly, and then subsequently annual scan there can be done. And if any of these considerable factors are present, then we can go for the active treatment, which include first to see for any succinate dehydrogen mutations, cranial nerve palsy, secretory or not secretory, size of the tumor, Champlain's classifications, rate of the growth of the tumor, age and comorbidity status of the tumor, and the risk of the operative morbidity. So if consider if any of these patient is having a comorbid patient with a low risk of SDH mutation, in those patient we can go for the active surveillance. If we are thinking of considering surgery, so the surgery can be done in the small low class Chambline's tumor, pre-existing cranial nerve palsies, secretory tumors which needs a pre-operative alpha blockade, younger patient otherwise well, the tumor which is rapid in growth, and tumor which has HDHB mutation because it has a higher chance of metastasis. And if we consider radiotherapy, though the patient comes under the radiotherapy in the radiotherapy class. So the tumor which has a large and a high class Chamblian tumor can go for the radiotherapy. High risk operative morbidity, non-secretory tumors, elderly comorbid patients, there's no evidence of any rapid growth or a concern re-malignancy, or there's a no chance of recurrence following surgery. In these cases, we can consider a radiotherapy. If tumor recurs after surgery, then it can be followed to the radiotherapy. So the management for non-carotid body tumor is also almost same. The only factor is that we have to consider if the patient is jugulotympanic and vagal paragangliomas. So this has to go for the first jugulotympanic classification by Fish, class C and D. First go for the active surveillance, which includes clinical examination and radiological follow-up first 6 monthly and then after annually. And if the jugulotympanic paragangliomas comes under Fish classification A and B, in those cases we can go for the active treatment, which includes which can include consider surgeries and consider radiotherapy, the same factors which was for carotid body tumors. So the first surgery, the most common point to keep in mind for paragangliomas is according to the location. For the carotid body tumor, the stroke is the most common factor. There's a meta-analysis by Janssen et al. In 2018, in which they have says that post-operatively there's 1.9% in grade 1, 2.7% in grade 2, and 4% in grade 3 cases of stroke reported. And perioperatively, there's almost 4% chances of stroke. For vagal tumor, the chances of cranial nerve palsy, iatrogenic, reported more than 50%. There's an article by Shores et al., which published in 2013, which says that more than 50% cranial nerve palsy reported iatrogenic. For jugular, it is more than 85%. And for tympanic, it has a minimum morbidity with a complete tumor resection. This is the best tumor for the surgical approach. So, however, these are the complications for surgical resection. The surgical resection achieved with a cure rate of more than 95%. So the factors which support active surveillance as on a non-carotid body tumor was support active surveillance. This is also for class C and class D. This is also by Janssen et al. In 2018. And surgery with a cranial nerve incidence leads to symptoms such as dysphagia, dysphonia, facial paralysis, and CSF leak. This is there's an article by head and neck paragangliomas for 30-year experience by Jatin Shah, which is published in 2020. A rare but debilitating complication of jugular tympanic paragangliomas or a vagal paragangliomas. The surgery after surgery is the first bite syndrome, which has a severe pain at the beginning of the meal consumption. Coming to the radiotherapy for the paragangliomas, there's a systemic review and a meta-analysis on a regression and local control rates after radiotherapy for jugular tympanic paragangliomas, published in 2013. with a cohort of 276 patients, with the average dose they have given 45 to 50 grays of EBRT and 14 grays for radio surgeries, which is usually lesser dose than we conventionally use for head and neck cancers. And they have said that the local control proportion for radiotherapy as initial, combined, and salvage treatment range from 79 to 100%. There's another article on a definite radiotherapy, the management of head and neck paragangliomas of 35 experience by Russell et al., published in 2008. They have total 121 head and neck paragangliomas in 104 patients, out of which 98 patients received conventional dose of 45 grays, and 6 patients has a radio surgeries, in which 3 patients received 12.5 grays and 3 patients received 15 grays of dose, and has reported a local control and a cause-specific survival rate at 10 years were 94% and a 95%. So the management, coming to the management of malignant head and neck paragangliomas, so head and neck paragangliomas can only be considered malignant once it's spread to non-neuroendocrine tissue. So the treatment option for them is surgery, radiotherapy, chemotherapy, peptide therapy, and immunotherapy. Surgical option as a surgical option should be opted for a symptomatic patient due to either excess catecholamines or a mass effect. Radiotherapy should be considered for the tumor shrinkage, not for the and the patient which is not a surgical candidate. Chemotherapy has a historical importance, and recently peptide therapy and immunotherapy have shown some hope in the treatment of distant disease, and these are in the phase 2 trials. The survival of the patient with malignant head and neck paragangliomas reported 5-year survival rate range between 12 to 85%. The 5-year relative survival rate was 59.5%, in which 76 for regional and 11.8 for distant. Among patients who were followed until death, those treated with adjuvant irradiation had a longer median survival of 45 months compared with those patients who were treated with surgery alone. Coming to the surveillance versus post-operative follow-up of the head and neck paragangliomas. For the surveillance, the clinical examination should be done, including cranial nerve examination from level 7 to level 12, and a formal audiology testing should be done. The British Skull-Base Society suggests an initial 6 months imaging followed by an annual scans thereafter. And post-op follow-up says, in a post-op follow-up for head and neck paragangliomas, patient with elevated perioperative metanephrines level undergo repeat testing 2 to 6 weeks post-operatively to confirm complete resection. If there is a persistent catecholamine excess, implies either it has a incomplete resection or there is an occult synchronous tumor are present. And baseline post-operative imaging should be performed 3 months after surgery to assess for the residual disease. So the take home from this presentation says that although head and neck paragangliomas should be, although it is a rare, head and neck paraganglioma should be considered when a mass is seen within the carotid space, jugular foramen, middle ear, or along the course of the vagus nerve. There should be a site-specific imaging. Genetic testing is recommended when suspected. Biochemical testing before embarking upon treatment or observation, and the optimal balancing of tumor-induced and treatment-induced complications should be considered. Thank you, sir.
Thank you, Akshan. It was a nice presentation. So, basically, your approach to a patient? Let us take two scenarios. One is a scenario in which a patient is a 28-year-old lady with a carotid Chamblin 2 carotid body tumor. Okay, and uh, yeah, so how would you go about that? And you have a similar Chamblin 2 in a 67-year-old male uh, 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 paraganglioma carotid
So,
body tumor. So how
uh,
would you be different, or would it be the same?
no, sir, the treatment would be different for both the scenarios. First is that the tumor rate, growth rate for head and neck paragangliomas are really slow. But when the comes to the younger patient, if the younger patient diagnosed with Chamblin 2, so it is already a greater size tumor. So with the age of increasing age of the patient, the tumor also grows, and by the age where we think that it can create more cranial nerve palsy, it might become inoperable. So in these cases, for the young patient, female patient, so we can go for the and the smaller tumors like Chamlin's 1 and 2, we can consider a surgery. And for older age patient, if patient is already 67 years old and the growth rate is extremely small, so in that patient we can actively observe those patient. And yes, sir.
Why can't you radiate? Uh, because she is 28-year-old. What are the three major complications after doing? You want to do a surgery for a Chamblin 2 4 centimeter by 4 centimeter carotid body tumor, right?
Yes, sir.
Okay, and you say you justify it by saying that she is young. The
Yes.
tumor may go or grow, and you don't want to consider, and you feel confident that you can surgically extirpate the tumor. And you feel that it would be much difficult to operate her at a later date if kept on active surveillance. But
Yes.
with surgery, when you counsel the patient for surgery, what are the three major complications you would be counseling her for? Uh, First being the most common, and the third being the least common.
So the first is the cranial nerve palsy. uh,
Cranial nerve palsy.
Ma'am, ma'am, ma'am.
uh, Glossopharyngeal, then there's sort of hypoglossal. These are the
Okay,
nerves in these palsy.
in a carotid body tumor, what is the most common cranial nerve palsy you are expecting?
The most common is the vagus.
Vagus, right? So what will happen with vagus?
The patient has the sort of hoarseness of the voice.
Will have hoarseness of voice. Okay. Okay, that is one. Then what else you will tell?
Then, sir, next is the chances of stroke were reported, although it's very rare, sir. But in if it's secretory in nature, patient is young age, we can consider about think about the genetic testing. So second is mine. Second is genetic testing, and according to that, I'll go for yes, I will go. I can go for the further treatment. And third is it's a Chamlin
You know,
2,
we are
so
talking
it is.
about Afshan, we are talking about the complications. See, you want to convince the patient to go for surgery,
Yes.
right? But
Yes.
you need to tell the patient regarding major complications expected out of that surgery, right?
Yes, sir.
First, one of the complications you mentioned is the injury to the or cranial nerve palsy. Okay, in
Yes.
that you specifically told about vagal palsy causing hoarseness,
Yes, sir.
right? Now,
Yes,
what
sir.
else? What is the next thing which is most common or relatively common after these surgeries?
So next is, sir, stroke only, sir.
Stroke. Okay.
Yes, sir.
What
And
else?
then in these patients are for Shamlin's
You're
in
getting
these.
my point. So we are arriving on on a discussion that how do you weigh the morbidity of resection versus alternate therapy. Okay.
Yes, sir.
So what is the so now if you tell a 28-year-old receptionist, she works as a receptionist in a nice gymnasium, and you tell her that she's essentially come to you because of the neck swelling, and you say, I'm going to give you a scar, I'm going to remove this lump in your neck, which is not cancer, but then I'll make you horse for life.
Yes.
Would she agree, or
No, sir.
how convinced? And then on top of it, then you tell her that she will have increased risk of stroke. She will
So
be scared.
yes, sir. But the sir for Shamlin's one and two, there's a chances of cure rate was 95%. Even if the rate of the complication was higher, the surgery shows a good result, sir. So for these
Okay, you will
patients,
tell her that I'll be very sure, and your recurrence rates are quite less. So she'll be convinced, okay, but then she'll be like, do you have any alternate?
so radiotherapy is option, but it has a doesn't have it has a control rate. It doesn't remove or it doesn't it cure the tumor. It just control or shrink the tumor. So, sir, over this radiotherapy surgeries are more better for the young age group, sir.
Okay. So yes, when you can control the morbidity, okay, and limit the morbidity, then surgery has an increasing role. Also, when you feel that radiotherapy itself would not be and a patient is it is rapidly progressing, patient is developing cranial nerve palsy. Okay, it may involve further nerves medially. Those are the telltale signs in which you would consider surgery and consider a damage control algorithm to offer surgery. Otherwise, there is growing evidence that this modified grade of radiotherapy shrinks this tumor and controls this tumor quite effectively. Large series from Canada, from Europe. So the treatment paradigm is slightly changing even in these Champlain 2. See, in Champlain 1, it's straightforward. Your morbidity is going to be very less. So you will take the patient for surgery and you will not do. Okay,
Okay, sir.
right? Okay, so
Yes, sir.
surgery is it's very clear that for limited morbidity, please offer surgery. But
भागल
for
क्यों मैं
uh, uh,
हाँ
for uh, for debilitating morbidity, and there is no evidence that it
he
has
was in
already
boring roadies
caused cranial nerve compression involvement. You
हाँ
may consider
this traffic
radiotherapy
actually ज्यादा रोड
also.
है
Okay, so you give that option
मैं
to
फोन नहीं उठाया
the
मैंने
patient.
बताया
Okay, and then then decide. Also, you see the growth rate at times, and then offer surgery, because your surgery will come with this morbidity, Horner syndrome. Okay, there are a lot of other morbidities which you should be talking about in the surgeries for. Okay. Yes, Rakesh is saying that there may be increased risk of carotid blowout in shambling tree after RT. Uh, uh, it is there, but it is very less. Like, it's not that high. So that risk remains even after surgery, and you always will keep a vascular anastomosis ready at your disposal whenever you are operating patients with carotid body tumor. Okay, so now you would like to you have decided, you're convinced her beyond a doubt that she's ready to get this surgery done. How do you prepare for surgery of shunt?
So, I'll first do the initial workup for the surgery, which includes the post imaging, followed by a biochemical testing. In imaging, I'll go for the MRI, and then biochemical testing. If biochemical testing comes positive for metnephrines, then in those cases we can go for the PET CT, functional images like PET CTs, to see other tumors in all over the body. If any tumor which is shown outside the head and neck region, we should consider for multifocal tumors. So in that cases, we can consider the genetic testing, and
That is fine. I'm telling you, it is an isolated tumor in the neck. You have done all that workup. It does not have any signs of secretory. See, you rightly mentioned in your own presentation, right, that most of the head neck paragangiomas are non-secretory.
yes.
Okay, secretory are very less, very few, compared to already they are only less than 1% of all head neck tumors. In that also, secretory are 30%, less than 30%. Okay, so it's quite rare. And secretory, you will come to know. Patients will have symptoms. Okay, patient by that time, by 28 years of age, will have a lot of symptoms to tell you that patient will have it's a secretory paraganglioma. So let's consider all that workup has been done. When you want to plan the patient for surgery, what are the basic concerns you will have when you do a shambling 2 case in which the degree of encasement is around 180 degrees?
Sir, we can approach to the horizontal incisions in the neck, and followed by sir, in these patients we
Anything
can.
specific? See, anything what I'm leading you to is that how would you manage the carotid artery? Okay, and surgical management of the carotid artery is important. Okay, so how do you consider managing the carotid artery, the internal carotid artery? What all preparations you would do? Okay, and if you had to resect the carotid artery, uh, uh, how would you reconstruct? Whether would you consider it or not? How would you go about it? And would you like to get certain workup done before you embark on these surgeries?
So, in workup sense, we can go for the angiography, and the embolization has to be can be done, but
Very
I'm
good.
still not aware of the reconstruction for the internal carotid artery. Sir, I have to read about that. And
See, that is precisely. See, we were all just a while ago. You wanted to operate her, right? Right. So now she's ready for surgery. So now you need to be very, precise and prepared. Now, how are you going to go about? right?
Yes.
So one thing you pointed out rightly, that okay, you want to go for embolization, so you will call up your intervention colleague and radiologist that I want embolization. So what is the protocol of embolization? When do you embolize, and how long? What's the time interval you all plan? And what is the evidence of, if at all, embolization really works in these cases?
Sorry, sir, I am not aware. I have to read about this.
You should add that. Okay, those all, I think, although the focus of your presentation was only on diagnosis and initial workup and the treatment algorithm, I urge you to further read on how you are going to do the surgery for these cases. See,
Okay, sir.
those cases in which it is Champlain free and involvement very large tumors, you may not offer surgery at all. Okay, so that is a no-brainer, right?
Yes, sir.
Okay, but but in cases where you're going to, could you offer a balloon occlusion test? And how do you interpret a balloon occlusion test? And why would you do it?
Okay, sir. I'll also
Okay,
read about this. Yes, sir.
for that you anybody? Uh,
तूने देखा सैडल ब्लॉक कैसे करा है? नहीं दिए सैडल नहीं दिए फिर मोडल ब्लॉक किए हाँ
Okay, so
नहीं देखा
it is
मैं
important that we work
पेशेंट
up
को
the patient.
सर मेरा
You need to know about your yes, Ahmed. It is to see
femoral block
the
किए उसको
basically the circle of Willis, not exactly the dominant vessel, but yeah, you. I think you have a fair bit of idea why you do it, and then it is important to consider what kind of, if at all, you're partly resecting the carotid artery. Okay, what kind of vascular graft you would place? Would you put a Dacron graft, or would you put autologous graft? What are the options you have? In what setting you would like to offer? Okay, all these are very pertinent questions related to surgery, which is important. Okay, now coming on quickly to, do we have time? What is the time? Okay, we are almost done. In 5 minutes we'll wind up. Akshan, sorry,
Okay, sir.
or you all have any other commitments, and we'll call it a day. Okay, so regarding the other scenario, 67-year-old male patient with a 4 into 4 centimeter carotid body paraganglioma, vagal paraganglioma.
Uh,
What do you
versus for 67 years old, I am embarking more towards observation with active surveillance, sir.
Now,
And if the patient is
you kept the patient on active surveillance after 1 year. After 1 year, patient is now developing signs of hoarseness.
in those patients, I'll go for just check for the any sir. It's a Champlain 3, so I'll go for the radiotherapy rather than for surgery because, sir, as you said earlier, also for Champlain 2, also we can
एसी
go
नहीं
for
काम
the.
करता है तो यही
We
ऐसा
can
लगता है
consider,
it's
but see
like
now in this scenario, when you are having a
it's like
Champlain, but the patient
हाँ
is just 67-year-old.
when I
Does
came
not
here
have
we
any
joined in
other
April ना मेरा
comorbidity,
एसी तो
then
घर से आया है
you know that now
तो
it is
हाँ तो
rapidly
it
growing,
came
because with
around
increase
August
of
I
age and
think
increase of age, you know that the
तो
presentation
3-4
and
months
outcomes are
मैं
also
इसको
poor.
ही खरीद के यूज़
So
किया
you would consider case by case. So just because it is 67,
तब
don't get
मेरे
into
पास कुछ
that trap
सामान नहीं था
that
सिर्फ ये था
you want
और
to
आई
keep on
हैव ओनली
surgery. Okay, because now
हाँ
in
जमीन
follow
पे
up,
आई
the
वाज
patient is
पुटिंग
developing
दैट
signs of
गद्दा
nerve involvement,
फिर मेरा धीरे धीरे
right?
सामान बढ़
You
गया
don't want morbidity to worsen.
ये
Okay,
अलमीरा लिया
you
ये
may
लिया
consider surgery also in that, or a debulking surgery. You may not want to do an extensive
3
carotid
years
artery and all
विदाउट
that,
एनी अलमीरा
but you
मेरे
debulk
फ्लैट
the
में
tumor
अच्छा है सुंदर है
and
पर
you
अलमीरा
reduce,
एक भी नहीं है
Yes, sir.
right? Okay, so debulking is also an option.
मैं तो
Okay,
आपसे ज़्यादा
so
देती हूँ
that is one. So now the
11
last question:
देती हूँ.
what are the targeted therapies you are aware of
For
for
head and neck
आप
paraganglioma,
10 में भी शेयर कर
not
रहे हो.
aware. Only the peptide therapies I'm,
मस्त है ना.
which are the
Sorry, repeat the question, the option.
sir, please repeat it again, sir.
Targeted
So
therapies,
you people
okay,
will share your
for
electricity bill
head
ना.
and neck paragangliomas or metastatic head neck
तो जब
paraganglioma.
दोनों लोग का हाफ हाफ होगा तो इट्स गुड ओनली.
So I'm not aware about, sir.
Okay, chal, koi nahi. Okay, good. So there's more reading to this, which is
Yes.
required, I feel. Okay, and a very nice presentation. Please do share this presentation. And
You
any
it's
other
very shaky.
questions from the audience,
You are very
or
shaky.
or anybody would like to
You
make a
are very
point?
shaky.
Please go ahead.
मैं नवीन सर का स्टेटस देखती हूँ. अभी सर पहले सर्जरी डालते थे, आज सर जिम का वो डाले थे. तुमने देखा क्या?
हाँ मुझे भानु भी बोल रही थी आई विल